Hello everyone, this is Dr. Sumit and I'm a head and neck surgeon and a maxillofacial surgeon. Welcome to the third lecture of our midfacial fracture series, and the topic that we are going to cover today are Lefort 3 fractures. So what you see on the screen over here is a maxillofacial skeleton and a midface. Alright, so the line that I'm about to draw over here, that line depicts the Lefort 3 fracture line. This exact one. So this line over here, this is the Lefort 3 fracture line, and look at its extent and look at how it extends from part A to part B. Alright, so line again begins at the junction between the frontal bone and the nasal bone over here. It moves laterally through the superior part of the ethmoidal sinus. That is the junction between the frontal bone and the ethmoidal bone right over here. Next, this line moves on to the medial wall of the orbit a little deeper than what the Lefort 2 line goes medially. Alright, so further medially, you have the superior orbital fissure over here, which I'm labeling as SOF. Next, this line goes further deeper on the floor of the orbit. It fractures the floor of the orbit, and a part of the line, at this point the line bifurcates. A part of the line goes posteriorly and inferiorly, and the second part of the line, it goes laterally towards the lateral wall of the orbit. It fractures the junction between the zygomatic bone here and the greater ring of sphenoid over here, and it goes on superiorly to fracture the junction between the frontal bone and the zygomatic bone, that is the Frontozygomatic suture. Alright, so this is the extent of a Lefort 3 fracture line when we go from medial to lateral. Let us just do a brief revision in within 10 to 15 seconds. Line starts at frontonasal area, extends laterally towards the junction between ethmoidal and frontal area, then on the medial wall of the orbit fractures the lamina pepritia right over here. Alright, then it goes medially just below the superior orbital fissure, and then fractures the floor of the orbit right over here, fractures the lateral wall of the orbit, which is the gap between the sphenoid bone and the zygomatic bone, and finally it fractures the frontozygomatic suture. But this is only the mediolateral aspect of the line. There is also an anterior-posterior aspect of this line, which we are going to see over here in this particular diagram. So like I said, this line has two extents. Look at this. The first extent we have already discussed over here in this part, which fractures the floor of the orbital cavity, comes up and then fractures the frontozygomatic suture. But there is a second line which goes far posteriorly, and then it fractures the inferior orbital fissures, enters this area that I've marked in the square. This is called the infratemporal fossa, or the ITF. This line passes through the ITF, goes down below, and finally it meets the maxilla at the same point where the Lefort 1 and Lefort 2 fracture lines meet. That is, it will separate the maxilla from the pterygoid plates, which you so kindly see over here. So if you actually evaluate the extent of this line is dividing the face into entirely two parts. Look at this. So this is the entire fractured segment, which you see over here, which I have marked and shaded in a blue area, and the rest of the fragment is the mandible down below and the cranial base above. So this kind of a disjunction is called a craniofacial disjunction, where the entire face gets disjuncted or gets separated from the calvarial cavity and the mandible. So again, if we see this on a CT scan, this is what it looks like, my friends, and have a good look at this particular CT scan. I'm going to help you in interpretation of this particular CT scan. Alright, so this kind of a CT scan is called a 3D reconstructed CT scan. Alright, so over here, if you see the fracture line, of course, it's not a classical Lefort 3 fracture line, which should have extended till the nasofrontal area, but still it's a little down below, it's fracturing the nasal bases. But look at this line is coming medially on the medial orbital wall. Next, this line over here, this line is fracturing medial orbital wall, orbital floor over here, rim of the orbit. This line traverses towards the lateral wall of the orbit and then finally fractures the frontozygomatic suture. Alright, now The next thing that we know is a line which extends posteriorly, fractures the inferior orbital fissure, and then finally it's going to fracture the zygomatic arch. So now do you see the area which gets completely fractured, and this junction over here, this area is the area of craniofacial disjunction. You can also see a complete Lefort 1 fracture as a part of this Lefort 3 fracture over here, where the maxilla is completely separated from the pterygoid plates. So again, coming back to our analysis, if we analyze this entire deal, okay, if we analyze this particular X-ray, what do you think are going to be our clinical features if you have a fracture like this? Okay, so let's evaluate this line and let's evaluate this for the clinical features. Number one, of course, the moment you fracture the frontonasal junction, you have the olfactory nerves coming out from this area, which are responsible for the sense of your smell. So the patient is going to get something called as anosmia. The patient is going to have anosmia or a loss of sense of smell. Next thing, like I said in the Lefort 2 lecture, there is a dural lining over here which covers the brain. If there's a tear in the dural line, you are going to have a dural tear, and then the cerebrospinal fluid will come leaking from the nose, and that is called a CSF rhinorrhea. Alright, like I said, there's going to be a separate lecture on that, no need to worry. Next thing, it is going to completely change and disfigure the shape of this orbit, and that is why there is either going to be a hypoglobus or there is either going to be an enophthalmos. You'll have to calculate the volume of fat that is lost and the entrapment of muscles that are entrapped in this fracture to completely treat an orbital fracture, which will be definitely covered in the orbital fracture lectures. Now, let's focus on the Lefort 3 line. This is going to have systematic changes in the zygomatico-maxillary complex. Alright, the face will lose its dimension. Because of fracture in the FZ, this entire fractured fragment will come downwards. There is going to be an asymmetry in the face, which is going to be very obvious on observation. Next thing, this patient is going to have sinusitis. Why? Because there is a concomitant Lefort 1 fracture that is seen over here. And last thing you can imagine is, if you have the entire part of the face coming down, the length of the face will be elongated, and it will be a dish-faced or an elongated face deformity when it comes to a Lefort 3 fracture. Apart from that, if we observe the other clinical features, see, so obviously the fractured line is going around. So let's talk about the soft tissue changes. If this fracture line goes all around the orbit, there is going to be periorbital edema, periorbital ecchymosis, and of course there is going to be subconjunctival hemorrhage. All of these factors, all of these orbital ocular factors, they are going to be clearly seen in a Lefort 3 fractures. So when you have bilateral periorbital ecchymosis, you start looking like a panda or you start looking like a raccoon, and that is why this is called raccoon faces or panda faces. So let's have a brief revision of the clinical features as given beautifully by MediStudyGo. Alright, they have completely revised it in a very few short points. Separation at FZ suture, bilateral circumorbital ecchymosis, like I mentioned, periorbital edema, like we mentioned, epistaxis, that is bleeding from the nose, like I explained, subconjunctival hemorrhage, that is the white part of the eye, it starts looking red and it stays red for a very long time, as you heard in the Lefort 2 lectures. Flattening of the nasal bridge, of course, because you have a nasal fracture over here at the dorsum. Anosmia and CSF rhinorrhea. I've already explained that. There is going to be change in the shape of the orbit, like I said. Okay, so either you can call it a hooding or you can call it enophthalmos or hypoglobus. There is a mongoloid slant in which the eye becomes like this, the lateral canthus goes up, and there's an anti-mongoloid slant in which the lateral canthus come down, and then that is a hooding. Alright, so you can have any of these slants which are called mongoloid or anti-mongoloid slants. There is going to be hypoglobus. Step deformity at every fracture. We have been talking about a step deformity since we talked about mandible fractures. So a step deformity is mandatory almost in all the displaced fractures. Apart from that, long face syndrome. Like I said, the face becomes elongated. Okay. Apart from that, the other clinical features include malocclusion, mobile teeth, and a posterior airway obstruction, as explained in Lefort 2 fractures, that the entire midface comes down and gets retracted posteriorly because of the envelope of the skin covering it. And that is when you have a posterior airway obstruction, where the base of the tongue and where the maxilla will completely impinge on the posterior pharyngeal wall, and that is why you can have a posterior airway obstruction. So MediStudyGo has beautifully explained these points. It's my turn to explain some of my points and the Viva questions. Clinical and radiological features and Viva pointers. Raccoon faces, you're going to be asked about that. That is bilateral, periorbital, hemorrhage and ecchymosis. Dish face deformity, of course, because of the elongated face. Craniomaxillary disjunction, because your entire face is going to be disjuncted and separated from the cranium. CSF rhinorrhea, because you have a dural tear at the cribriform apparatus. Anosmia, because your olfactory nerves gets damaged when there is a cribriform apparatus fracture. What is a halo sign? Halo sign is something that we are going to talk about when we talk about CSF rhinorrhea. Okay, and snail track marks, same thing. A pathognomic feature of a CSF leak are halo signs and snail track marks, and I'm definitely going to put up about it. All right, next, how do you plate a Lefort 3 fractures? What are the different approaches that you're going to use? So of course, first I need to show it to you what a Lefort 3 plating looks like, and only then I'm going to discuss the approaches with you. So look at this. What are the areas that we are planning to plate? Number one, the junction between frontal bone and nasal bone. So frontonasal area is what we are going to plate. This can be exposed through an existing laceration. This can be exposed through a glabular incision. This can be exposed completely through a coronal incision, which exposes the entire area. Now you have to understand one thing. Okay, there might be a situation in a Lefort 3 fracture that you might have to place a plate on the frontozygomatic area. That is compulsory, but a second permutation combination might come where you have to expose the body of the zygoma. And what is the best incision to expose the body of the zygoma? That is the bicoronal or the coronal incision. So technically speaking, with help of a coronal incision, you will be able to expose frontonasal area, frontozygomatic area, and the body of the zygoma and the zygomatic arch as well. So in a way, Lefort 3 fractures can be treated only via a single incision. That is going to be a coronal incision. Apart from that, if you have an extra fracture line over here at the inferior orbital rim, in that case you might have to go for either a transconjunctival or a subtarsal or an infraorbital incision. All right, so that is exactly how you place a plate. What are the plates that you're using? So midfacial fractures, there are very thin bones, so the plating system that you're supposed to use is 1.5 mm plates that are pink in color. Second system is a 2.0 mm system which are going to be blue in color. Okay, so either 1.5 mm or 2 mm system plates which you're going to have to use for this kind of a fracture. Next, look at the approaches and look at the reduction. So again, MediStudyGo and Mind Maps has provided a very beautiful illustrated algorithm over here. Lefort 3, you can approach it through existing laceration, upper and lower glabular incision, upper eyelid incision, and a coronal incision. As I explained, this is a pure revision of the same thing. Okay, how do you reduce it? You have to manually move all the moving parts, and that is how you expose and you reduce a fracture using any of these instruments, that is Rowe's disimpaction forceps, Hayton-Williams forceps, and bone hooks. All right, and fixation I've already explained. You have to use 1.5 mm or 2 mm system plates that are pink or blue in color, and the length of the screws does not have to exceed 10 millimeters so that it does not enter any of your vital structures. Now it's time to just go through a basic revision. So what incisions can you take? Upper eyelid or the blepharoplasty or the upper blepharoplasty incision. Subciliary, subtarsal and infraorbital are 3 incisions over here. All right. Transconjunctival incision over here can be taken through the conjunctiva, that is the junction between bulbar and palpebral conjunctiva. Apart from that, the 3 incisions over here can be taken in subciliary, below the tarsal, that is the subtarsal, and in the infraorbital groove, that is the infraorbital incision. And of course, the key to everything is a coronal incision. Let me show it to you. How do you plate a Lefort 3 fracture? Number one, if you want, so this is one of my operated cases. Okay, now have a look. This is the superciliary arch. This is the frontal bone right over here. This is the nasal bone. So look, we have already placed a plate in the frontonasal area. So this is through an existing laceration approach. Let me show it to you. How do you do it with a coronal incision? So look at this. In this case, I've taken a coronal incision. That way is the lower face. That way is the upper face. Okay, I'm just orienting it for you. This is where the orbits are. We are looking at the patient from an upside down view. Look at this frontal fracture. I have placed all the plates at the supraorbital and the superciliary arch over here. And this little plate over here is stabilizing the nose with the frontal bone right over here. How do you place a plate in the infraorbital area when it comes to Lefort 3? Look at this. So this was a massive fracture where there was a complete comminution of zygoma and everything. Okay, so in order to plate this fracture, I had to take a big infraorbital incision. As you can see, this one is a pinkish 1.5 millimeter system plate, which I've used at the inferior rim of the orbit. Okay, and finally, this is a hemicoronal incision. This is not bicoronal, this is hemicoronal. So as you can see, we have taken a question mark shaped incision over here in the preauricular area. So I'm going to mark out the structures for you guys. All right. So if you see the structures, number one, zygomatic arch over here. Number two, this is the body of the zygoma. Number three, this is the frontozygomatic area. This is the frontal bone. So look what we have plated. We have plated the zygomatic arch, the body of zygoma. Okay, look at this. We have plated the body of zygoma right over here, and we have plated the frontozygomatic suture over here. That has completed my management for a Lefort 3 fractures. But again, this is not the end of the lecture. We have some very, very interesting flashcards and very, very interesting MCQs coming up for you guys. All right. So please stay tuned. There are 2 more parts of this lecture right here coming up in the next clip. Thank you.